Extract 1. Questions 1 to 12.
You hear a physiotherapist talking to Linda, a woman who has lower back pain. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hi there, Linda. My name is Sia, and I am one of the physiotherapists here.
Hi Sia.
How could I help you today?
I've been getting a pain in my lower back, on the left side, around my hip and through the bum cheek area, when I'm running especially.
Okay, how long has this been going on for?
It's something I've had on and off for years. And it started off as just a kind of dull pain, and now it really feels like it's spasming or something. It hurts even when I put weight on my left leg. Usually I feel it start, and if I kind of lie on a tennis ball and massage through the muscle, it goes away. But lately it's just been getting worse, and I can feel it sort of tight through my whole hip area. And I can also feel it kind of even when I'm sitting and sleeping, or at night when I'm trying to sleep. If I roll, I feel a kind of, it's hard to explain, it's like a shooting pain that travels down my leg.
Okay, so the shooting pain, where does that go?
It starts in the same place, and it goes like down the back of my leg, kinda through the back of my knee, and sometimes down to my ankle area. The pain also aggravates while doing exercises.
Okay. Are there particular exercises that do it?
Mostly, while running and walking. I think walking is even worse, actually.
Interesting. How long can you walk for before the pain starts?
I don't know. I kinda don't notice it when I'm walking, it's when I stop and then start again, yeah. So, I guess if I walked for. I'm a middle school teacher for the past 10 years and I walk every day to work. For example, which is about 45 minutes each way, and then if I run a couple of times, and then I'll notice the pain when I'm walking towards the end of the week, and it gets worse with each step as I walk into work.
Okay. Tell me more about what you are doing for sport and physical activity at the moment.
I ride my bike probably 4 or 5 times a week, not very far, maybe just 15 minutes each time, and I run probably 40 kilometers a week.
So, other than the riding and these long runs, do you do any other forms of physical activity?
Well, normally, I usually swim a couple of times a week as well. But I haven't been lately because I've been really busy at work.
Okay. And you said that you've had this for a few years. What initially brought it on?
I don't know. I think, when I was younger I used to play soccer and I had an injury where I dislocated my hip, and it was really painful. I couldn't move for like a few weeks and I had a lot of physiotherapy and I had a lot of lower back pain after that for maybe a couple of years. But then it went away, and I haven't really had any major problems since then.
And, other than this dislocated hip on the same side, have you had any other major problems with your left leg, or with your back, or your hip or anything before?
Oh, no, nothing really.
How? I know that this has been going on for quite a number of years, but how long has this been a problem where you've sort of felt you need to do something about it?
I've been to an osteotherapist a couple of times about it in the past, just when it gets to this acute stage. So, this time it's only been like a few days that it's been really painful.
Okay, no worries. And what sorts of things did the osteo do for you in the past?
It was mostly putting pressure through that area, like massage, and then, think she used to just like poke her elbow into my left hip and hold weight there for ages until the spasming stopped.
Okay, no worries. How did you find the effectiveness of that?
It relieved it. So, basically what normally happens is it's still quite sore for a couple of days after I have treatment, but it doesn't feel so tight. And I usually have to rest off it. For at least a few days, and then it's gone. Or maybe it's still there a little bit, but it's not doesn't get aggravated, and then it just drifts away.
Has your osteo given you any exercises in the past for this problem?
I do like a stretch where I kneel down and stretch through my front like hip flex area, and another one where I cross my leg, kind of on an angle like that, across my knee, and stretch through there, and I can feel that through my bum cheeks.
Oh, good. Have you found anything else that helps the pain go away?
Not really. I mean, if it feels really bad I can take maybe a Nurofen or something and it makes it better, feel a bit better, but no other sort of exercise or stretching.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Oh, good morning, David. How was your weekend?
Oh, morning, nurse. It's a little bit tough, actually, this last weekend.
Yes, I'm sure it has been. I just wondered, could you tell me a little bit more about how it went?
Well, started on Saturday night. Jill had quite a restless night. There was breakthrough pain at time, and I was giving the medication, but I didn't feel it was as effective as it had been in the past.
So you have been giving the same medication regularly, but you're not getting the effect that we were last week, for example.
No, that's right. And, I could see by her expression that she was quite uncomfortable.
Mm-hmm.
So, yeah. And again, the same thing happened last night as well. Very similar
So
situation.
you've had 2 bad nights. And is she able to eat anything?
I have been trying, to give her, different things like food, but she really has only a small appetite and mainly just fluids.
Is she having much fluid?
A few sips, a few glasses of water. We have tried some green teas and various things, but that's about it.
Mm-hmm. And is she still able to walk around a little bit?
She did walk out, yesterday, and she went out into the lounge room, and, we got her to sit down and watch a little bit of TV, but she tires very quickly.
Mm-hmm. And what about her general mood?
She's not saying too much, and the kids are around too, but she, I get the feeling that she is getting a bit depressed.
Mm-hmm. And have you had any visitors at all to sort of break the monotony? And
not this weekend. I mean, we have been pretty lucky with visitors and people coming, but this weekend we didn't.
Right. Now, I know you've got the 2 boys, David. What age are they again?
The older boy, Michael, he's 13, and his brother, Tommy's 11.
I see. And how are they coping? What about school? Are they managing there?
To be honest, I haven't been paying too much attention. They say they're doing their schoolwork, but look, they're missing their mother because she was always the one who spent time with them after school, and she, now she can't really do that, and so they're sort of playing up a little bit.
Is the school aware of the problem? the teachers realise that the pressure that the boys
Oh
are
yes,
under?
yeah, the school's been great. There's no problem there.
Oh, that's good. And is there any family help that you can get?
Well, I have had some help from my sister, and she's been great. But, she's got her own job and family to look after, so it is getting a little bit tough, and I don't really want, and certainly Jill doesn't want it, to be a burden on other people.
Yes, I can understand that, although I think people sometimes feel a great satisfaction in being able to help. But how about you, David? Are you still doing some work?
I was up until about 2 weeks ago, but I'm taking a bit of a break. It is a little bit tough financially, but yes, I just want to be with Jill and make sure she's as comfortable as possible.
And are you getting any break from that at all? Sometimes just to get away by yourself for a little while?
Not actually recently.
No, well, I'm looking at you and you're looking very tired.
Yeah, I guess I'm a bit tired. But, look, I promised Jill that, we get through this, and so that's what I'm trying to do.
Right. David, have you given any thought to palliative care?
No, not a great deal. I mean, look, I promised Jill that she'd be able to stay at home, until the end. She likes this home, she's comfortable here. So, I'm just trying to do that for her.
Well, I think you've done a very good job. But sometimes it does come to a point, particularly with the breakthrough pain that Jill is experiencing, where there might be a better option with palliative care to see that she really gets as much quality of life as she can for the time left to her.
Yes, but I just have this image of hospitals, as busy places, and she won't get that personal attention that we've been giving her here.
Yes, I can see your concerns there. The thing to think about with palliative care is that the people who go into this field, the nurses who choose to work in a palliative care hospital, they do so because they're so strongly committed to care for people. I mean, some people would find it a very difficult environment to work in, but the nurses there get their satisfaction from knowing that they've done everything possible to make a person's end of life as pain-free and comfortable as it can be.
Right, I see. Okay. That doesn't sound too bad.
And you see, it allows the pain medication to be monitored very regularly. There's no delays. As soon as it's seen that there is breakthrough pain, the doctors can be called in and look at how they can really relieve that.
Do they have individual rooms and these sorts of things?
In many of the palliative care hospitals, they do have individual rooms. Another thing too is I believe you told me once that you had full health cover, your health insurance.
Yes, we do.
So in that case, that would help also to alleviate any extra expense.
Right. Well, I wouldn't want to be, if we did choose this, I wouldn't want to be restricted in any way. I mean, visiting hours and those sorts of things.
They're very liberal. You see, these hospitals really work on patient time, not hospital time. And if a patient is sleeping in the morning, well, they don't wake them. They let them wake up at their normal time. And so long as the visitors are not disturbing the patients, they're very welcome to spend almost all day with them. And in fact, if you're ever really worried, they'll set up a bed in the room and visitors can stay the night if they're close family members.
And in your opinion, you've seen Jill, you know the stage she's at. Do you think this is the right time to do that? Or do you think we can, I should just keep trying, and doing my best to care for her here?
Well, I think it would be a good idea, if you feel you can, to talk this over with Jill. But my feeling at the moment is that she is reaching the stage where she needs almost more care than you can give her, particularly in terms of the pain management. And the other side of it is that if Jill were in the palliative care hospital, you could devote your time to giving her comfort and talking with her without having the responsibility of worrying about medications or running the house, all the things that are taking up so much of your time.
Yes, okay. All right, well, I think I'd like to talk that over a bit with Jill first.
Well, I think that's a very good idea. Just one other thing I'd like to mention that you might like to consider. There is the opportunity to have spiritual support because local ministers from a number of churches visit regularly, and there are also counselling services. And for the boys, there is a special care counselling service. It's designed to help the children of people or parents with a terminal illness.
Okay, well, actually, that they might benefit from that because they, I have tried to talk to them about it, but it is hard for me to do that, so...
Well, sometimes they need to talk to somebody away from the close family environment. And certainly, if you would like, I can contact several palliative care places and I can bring you some more information about them when I come tomorrow.
Okay, no, that'd be really good. And if you could bring that information. In the meantime, I'll talk to Jill and we'll see if we can come up with a decision.
Well, that's good. Well, I'll help you any way I can, David.
Yeah, thank you. Yeah, thank you.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen. Complete the answers as you listen to the audio. Now look at question 25. You hear a physician and scientist making an announcement on a finding. Now read the question. A major depressive disorder is one of the most severe, troublesome, and costly psychiatric diseases. Although there are pharmacological and non-pharmacological treatments, often antidepressants are used more frequently than psychological interventions due to inadequate resources. Our efforts are to promote the evidence-based prescription of these antidepressants in the future. Therefore, we are now focused to update and expand our previous efforts to compare and categorize antidepressants for treating a major depressive disorder. All antidepressants were more efficacious compared with placebos while treating the adults with a major depressive disorder. While the effect was lesser in the placebo-controlled patients, the variation in efficacy and acceptability was more in the patients treated with antidepressants. Therefore, these findings should promote the evidence-based prescription of antidepressants and apprise the physicians, patients, and policymakers on the merits of various antidepressants. One of the most crucial challenges worldwide is the routine prescription of antidepressants for the treatment of a major depressive disorder. Nevertheless, in the scientific literature, there are considerable ongoing debates about the effectiveness of antidepressants, as well as the potential differences in tolerance and effectiveness due to individual drugs. With the introduction of new antidepressants into the market, and the increasing numbers of trials published every year, we have realized the significance of systematic review and meta-analysis to synthesize the evidence in this crucial clinical issue. Question 26. You hear a physician explaining the issues involved in treating lower back pain. Now read the question. Lower back pain is one of the crucial issues in the medical field leading to disability, and it's growing alongside the aging population, which are more rapid in low-income and middle-income countries, where adequate resources to deal with this issue might not exist. Therefore, the impacts are probably extreme in such regions. Most of the lower back pain issues are unrelated to particular identifiable spinal abnormalities, and this announcement is an alert for action on the global issue of lower back pain. Typically, most of the clinical practice guidelines suggest similar approaches for the investigation and treatment of lower back pain. Their suggestions include the use of biopsychosocial strategy with initial non-pharmacological treatment, including the suggestion of self-management and resumption of exercises, normal activities, and psychological programs for those with continuous symptoms. Nevertheless, recommendations are mainly based on the trials exclusively from high-income countries, focusing mainly on treatments rather than its prevention. Therefore, there is a massive gap between evidence and the existing practice. Without the use of suggested first-line treatments and inappropriately high use of imaging, spinal injections, opioids, and surgery. Following similar strategies will never reduce back-related disability or its consequences in the longer run. The effective treatment will be those which align the evidence with practice, focus less on spinal abnormalities, and suggestions of activities including work participation. Although we have devised effective and promising solutions that require greater attention and intensive research to establish whether they are suitable for larger-scale implementation. These potential solutions include the redesign of clinical pathways, focused strategies to implement best practice, integrated health, and occupational interventions to reduce disability with prevention strategies. Question 27. You hear a doctor explaining to the nurses about the growth hormone test. Now read the question. Growth hormone test. The growth hormone is very essential for the human body to grow. To find out why the growth of a child is slow, a growth hormone test called arginine and clonidine stimulation test is performed that will indicate the secretion level of growth hormone in the body. The child will be injected with two types of medicines during this test, namely arginine and clonidine, that will cause the body to secrete the growth hormone. Biochemically, the growth hormone reserve of the child is defined by the peak serum concentration after stimulation with a known secretagogue. While performing the test, nurses draw 5 blood samples at specific intervals to observe how many growth hormones the body is secreting. Prior to the test, the child should not be allowed to eat or drink anything except water after midnight. The test takes about 6 hours, so the child should be clothed comfortably. Generally, a short-sleeved shirt is suggested during the test. The nurse on duty should make sure whether the child is on any medications before scheduling this test, and they should explain to the parents of the child about the process and outcome of this test. The test will be performed in an endocrinology outpatient clinic, and the nurse should measure the weight and height of the child. Then the child will be taken into the patient room equipped with the intravenous catheter, which is used to inject the arginine into the child and to take the blood samples. However, the clonidine will be fed through the mouth in liquid or in pill form. This may lower the blood pressure and cause the child to sleep, so the nurses should keep on measuring the blood pressure of the child during various intervals. The child may be given fluids to drink during the test. However, before discharging from the clinic, the child should be able to eat and walk around. The child may feel tiresome throughout the evening. Question 28. You hear the announcement of a new milestone in cancer treatment. Now read the question. a milestone in cancer treatment. Cut, burn, and poison is the expression that describes the traditional 3 steps involved in the cancer treatment. Specifically, the expression means to cut out the growth of the cancer tumor, burn the carcinogenic cells with radiation, and poison those that remain with chemotherapy drugs. Interestingly, a young doctor from the U.S. proposed another method to treat cancer about 30 years ago. He thought that abandoning the blood supply to cancer tumors could block their growth, but many scientists dismissed this concept for a long period. However, last month, the Food and Drug Administration of the U.S. approved the drug called Avastin that works the way he proposed. Although the drug does not cure the cancer, it increases the lifespan of the patient with colon cancer. Avastin is a genetically engineered protein that connects with the protein in the human body that promotes the growth of the blood vessels. The protein, also known as vascular endothelial growth factor, intervenes with the supply of blood to cancer and starves the cancer cells. Avastin targets the weak places of cancer cells, though it does not damage normal tissue. Whereas chemotherapy kills cancer cells, and also the other normal cells, resulting in infections along with stomach and intestinal problems. There are also other drugs being tested to investigate whether they can stop the formation of blood vessels. In the past 2 years, Avastin is one of 3 new drugs approved for colon cancer. Question 29. You hear a physician explaining how to treat an intermittent explosive disorder. Now read the question. Intermittent explosive disorder. The intermittent explosive disorder involves spontaneous, impulsive acts of aggression that may take the form of spells or attacks. The symptoms may begin minutes or hours before the actual act. A person with the intermittent explosive disorder may have the frequent history of such occurrences. The intermittent explosive disorder can be connected to something in our surroundings or some kind of action within our body. Due to the abnormality in the area of the brain that controls the behavior, some people may show more explosive behavior, while others may develop the intermittent explosive disorder as a result of a severe explosion or violent actions occurring around them. People with the intermittent explosive disorder often show aggressive behaviors that are impulsive, and they often become out of proportion to the situation. They may experience the feelings such as rage, a racing heart, irritability, or sudden burst of energy. Often the patient with the intermittent explosive disorder will feel relieved from built-up tension, while many with such a disorder blame others for causing them to outburst aggressively. However, they also feel guilt and remorse after the outburst. There are various types of drugs to control the intermittent explosive disorder temporarily, such as certain anticonvulsant mood stabilizers, antidepressants. However, the therapy involving cognitive exercises challenging their negative perceptions was found to be effective in controlling the intensity and frequency of intermittent explosive disorder. Question 30. You hear a doctor briefing the junior doctors about trigger point injection. Now read the question. Trigger point injection. Often muscle spasm prolongs and doesn't respond to regular treatments like ice and heat, physiotherapy, or muscle relaxants. In order to relax the muscle, either a local anesthetic or a combination of local anesthetic medication and a steroid medication will be injected into the tight bundle of muscles known as trigger points. In this process, the skin of the patient will be cleaned, and chlorhexidine and a small needle will be inserted into the trigger point muscle. Generally, up to 4 trigger points are injected in one session. However, when injecting up to 10 trigger points, the patient will feel very painful. It is essential for the patient to inform the physician when the needle contacts the painful trigger point, as this is where the medicine has to be injected. They may feel a temporary discomfort. There can be many possible complications after a trigger point injection, including mild bleeding and skin irritation and infection. Although the positive result of the treatment cannot be ascertained, the local anesthetic will numb the area for 3 hours. The corticosteroids remain in the tissue in active form for about 1 month.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
I'm joined by Dr. Robin Steinhorn from Children's National, and we're here to discuss her talk on BPD-associated pulmonary hypertension. Welcome, Dr. Steinhorn.
Thank you.
Thank you so much for being here. Can you tell us what was the main objective of your talk?
Well, I think in my talk, with the brief time I had, was to increase awareness of how common pulmonary hypertension is in preterm babies, both early in those babies that have severe hypoxemic respiratory failure and later on associated with their bronchopulmonary dysplasia.
To follow up, how common is it in these preterm babies?
So in preterm babies, about 2% of them will have significant pulmonary hypertension in the first week of life, some so significant that it is life-threatening, and detecting it and treating it can be life-saving. More commonly, though, we see pulmonary hypertension associated with bronchopulmonary dysplasia when it's diagnosed at 36 weeks postmenstrual age. And in that population, in particular those babies that have moderate or severe BPD, we'll see pulmonary hypertension in anywhere from 10 to 40% of those infants.
How would you say is the best way to detect this pulmonary hypertension in the early onset group, these preemies who get it early?
So the answer would be the same for both groups, and I think it would be 2 things. First is being aware that this condition exists, and because you're not going to find what you don't look for. the best way to screen is with a cardiac echo. Now you have to really work with your cardiology team because pulmonary hypertension can be diagnosed with a tricuspid regurgitant jet, sort of that traditional way, but there are other more subtle signs. Septal flattening, right ventricular hypertrophy, right ventricular dilation can also be signs of pulmonary hypertension. This early group can also be important because what Pete Marani and Steve Abman have showed us is that if we see pulmonary hypertension, even these subtle signs in that first week of life, it's a powerful predictor of later lung disease and later pulmonary hypertension.
And if we diagnose pulmonary hypertension in these preemie babies, in your opinion, what's the best way to treat this pulmonary hypertension?
Great question, and one that we really don't have good answers for. In the first few days of life, if you have a preterm baby who doesn't have much parenchymal lung disease, or you've treated it and the lung looks fine, and that baby still has life-threatening hypoxemia, our recommendation would be to give a brief course of inhaled nitric oxide. We know that 90% of the babies will respond with an improvement in oxygenation, and survival is about 80% in what is clearly a very high-risk, very ill population. What we don't really know is later on in that child who has BPD-associated pulmonary hypertension, what is the best course of treatment. We do recommend considering treatment for babies who have significant pH, so pulmonary arterial pressure that is more than half, often more than 2/3 systemic, starting with monotherapy. Sildenafil, bosentan tend to be the two most common choices. But what we don't know is the length of therapy, and none of this has been optimized yet through randomized trials.
That's true. What would you say, Dr. Steinhorn, is the overall main point that you would like the audience to take away from your talk?
So I think there's a couple of points, is to tune your eye to the possibility of pulmonary hypertension. The preterm lung is disrupted not only in its parenchymal development, but in its vascular development as well. And so this is a very high-risk population. I think to consider pulmonary hypertension as a cause of hypoxemia, both early and late. And third, to remember this is a team sport. That in particular, these children with severe BPD, you're going to need a team that is very expert, not only in the lung support, but the pulmonary vascular support. So a cardiologist, ideally one that has expertise in pulmonary hypertension.
That's great. And how about, I know there's a lot we don't know about pulmonary hypertension in the preemie population, so where do we go from here?
Well, my hope is that increased awareness will inspire our community to come together and do the trials we most need. To me, it's pretty shocking that of all the drugs that are available for pulmonary hypertension, only one is approved in children at all, and that's bosentan. So developing that evidence base for what drugs we should use and when for children who clearly are at high risk, I think that's a really important problem to solve, and I hope the neonatologists here will participate in trials when they begin.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
New research from the Perkins Institute at the University of Sydney claims to have found the diet that boosts FGF21 levels. One of the lead scientists on the study was Samantha Solon-Biot of the Perkins. Welcome to the Health Report.
Thank you for having me.
So what is this stuff, FGF21? I mean, it's almost eye-crossingly complicated from the look of it.
Yeah, it seems complicated, but it's actually not. And recently, there's actually been an immense amount of interest in fibroblast growth factor 21, or FGF21. And this hormone has actually recently been called this fountain of youth hormone, which we know can be influenced by diet. And the reason why FGF21 is so interesting is because high levels of this miracle hormone, as it's called, has actually been shown to play a huge role in influencing appetite, improving metabolic health and immunity, and even extending lifespan in mice.
Now, something that sounds so good to be true is usually too good to be true.
At this point, there are no adverse effects shown with increased levels of FGF21. In fact, a lot of studies are now being done to investigate FGF21 as a therapeutic target for the treatment of diabetes and cardiovascular disease.
Let's just double back, Sam. A year or so ago, we had Steve Simpson, who's the director of the Perkins Institute, talking about this 25 diet study where they studied 25 diets in mice to see if you could replicate the life-prolonging effects of a low-calorie diet, where extremely low-calorie diets in some animal species, in fact all animal species, it seems, apart from humans because it's not been proven yet, increases life expectancy or lifespan. Is the FGF21 really the heart of this matter?
We think it actually could be. Certainly in this study, we've shown that a diet low in protein and high in carbohydrate is the most effective way to increase levels of this miracle hormone. And that this diet was also associated with several markers of improved metabolic health in mice.
So tell us a little bit about this study.
Well, what we actually did was performed a really large mouse study, as you said, where we took 858 mice and offered them a range of different diets to see how macronutrients, such as proteins, carbohydrates, and fats, as well as total energy, could interact and influence levels of FGF21.
And you found?
And we found exactly that we could use diet to increase the levels of this FGF21 hormone, and that a low-protein, high-carbohydrate diet was the most effective way for increasing this miracle hormone.
And what effect did that miracle hormone, I hate using that word, that phrase, but what effect then did the hormone have on these mice, or were you able to separate the two?
We were actually able to show that the exact diet that increased FGF21 also improved things like insulin sensitivity, glucose tolerance, blood pressure, and blood lipids, even though the animals were a little bit fatter.
And how do you know that was anything whatsoever to do with the FGF21, your so-called miracle hormone, and rather than it just being an accident that it was raised to?
What we did was plotted FGF21 using the geometric framework, which is a nutritional modeling platform that helps us tease apart the role of nutrients and calories. And if you line up all the surfaces, the response surfaces in this framework with FGF21 and all the metabolic outcomes, you can clearly see that there's a specific area in the nutrient space that coincides with increased levels of FGF21 and several metabolic benefits.
And what kind of carbohydrate, and what happened with fats?
In this study, fat did not appear to have an effect on FGF21 levels. It seemed to be low protein was the primary driver, and that the highest combination was with a low protein, high carbohydrate diet.
So what does FGF21 do to the body?
And that's a really good question. And that's really the next step of our study. We want to understand how FGF21 signaling works in response to diet to mediate all these beneficial outcomes.
Do we know that there are any medications affected?
At this point, no.
It seems that it goes up with starvation, it goes up with overfeeding. There's lots of things that influence it. Did the appetite of these mice change? Do they eat more or less when the FGF21 goes up?
Oh, that's a really good question. See, this is one of the things that we were able to reconcile in our studies. As you mentioned, a whole range of literature in previous studies have shown that FGF21 is elevated in many paradoxical conditions such as starvation and obesity, high intake of food and low intake of food, as well as in insulin resistance and in insulin sensitivity. So what is going on here? Using the geometric framework, we were actually able to tease apart these findings, showing that reduced protein intake is the primary driver of FGF21.
Okay, so what happens in mice does not necessarily happen in humans. How do you know it makes any difference at all in humans?
Oh, I'm glad you said that. We've actually published work just this year showing that FGF21 levels in humans is also increased by a low-protein, high-carbohydrate diet. And of course, this is really exciting because it tells us that the work that we do in mice can be directly translatable to humans.
So is there any evidence at all that FGF21 has the same beneficial metabolic effects in humans as it has in mice?
Yes, there is definitely evidence to suggest that high FGF21 levels is directly related and associated with several benefits of metabolic health in humans as well.
So we should put it in the drinking water then, do we?
Yeah, probably. That seems to be the case, yes.
How would it work? I mean, obviously, a hormone like this is probably destroyed in the stomach. This is not something that you would give directly to people, I assume, in the therapeutic context?
At the moment, it's difficult to do chronic administration to humans. So what's happening in terms of drug development is trying to develop mimetics of FGF21 and analogs. So not exactly administering this hormone per se, because it would require chronic injections or chronic administration.
So almost nothing that's touted as a breakthrough or a miracle by scientists turns out to be so. What are your modest expectations of FGF21 in humans?
Well, in humans, we actually think that FGF21 is extremely promising. We think that, at least in humans, we've shown that FGF21...
So a treatment for type 2 diabetes?
Absolutely.
That sort of thing?
Yes. We've shown that humans seem to respond in the same way as mice. So this could mean that we could tailor our diets and our nutritional guidelines to generate a range of benefits from FGF21.
Is it too blunderbuss? You're describing something that sounds blunderbuss rather than targeted. You're just spraying an effect rather than targeting an effect. If you can do anything with it, it's going to be a very wide set of actions which you're going to find hard to control, isn't it?
At the moment, everyone is very interested at FGF21, but no one really knows its mechanism of action. And it seems to be a race at the moment. How does it work? What turns it on? What switches it off? And what can we do to find out more about it? So at this point, I think it's a really hot topic and everyone's racing to find out the answer.
And you hope you'll be first.
Hopefully.
Sam, thanks for joining us on The Health Report.
Thank you so much.
Samantha Solon-Beat is a researcher at the Perkins Institute at the University of Sydney, and on our website we'll have a link to our previous interview on the diet and longevity study.